All right, let's jump right into a deep dive on BK Polyomavirus. Just so you know, all the information we're covering today was put together using a Gemini deep search. If you want to check out the primary sources for yourself, you can find a detailed list in the Notebook LM document linked below. So let's kick things off with a pretty staggering number, more than 80%. That's the percentage of adults walking around who are seropositive for BK polyomavirus. Think about that. It is everywhere. Most of us pick it up sometime in childhood, have no idea it even happened, and then it just hangs out. It establishes this lifelong, totally silent, latent infection. Yeah, that means most of us listening are probably carrying this virus right now. So if it's so common and so silent, when does it actually become a problem? Well, here's the key. Its clinical significance is almost exclusively a threat when someone is severely immunosuppressed. We're talking about the heavy-duty drug regimens used for organ and stem cell transplants. Those drugs are designed to knock down the immune system, but that also knocks down the surveillance that keeps this virus locked away. And when that happens, it can reactivate and cause some really serious disease. All right, before we get too deep into the clinical side, let's head to the bench. We've got to understand the basic virology here. I mean, what is this thing really? Its structure, its family tree, that's the key to figuring out how it operates. And here we go. This image really puts it in perspective. BK polyovirus is what we call a naked virus, which just means it's non-enveloped. It's got a double-stranded DNA genome, and it belongs to the Polyomaviridae family. And if you want to get formal about it, its official species name is Beta Polyomavirus hominis. Okay, now this table has some great info, but I want you to focus on that last row, the NCCR variants. This is really fascinating. See, there are two main forms. You've got the archetype, that's the stable version that gets passed between people. But when a person is immunosuppressed, these rearranged variants can pop up. And these guys are the troublemakers. They often replicate way more efficiently and are the ones we see in active disease. It's a perfect example of how a virus can evolve right inside its host. So we have this virus that can evolve inside the body. But how does it actually go from being a quiet passenger to causing all this damage? Let's trace the path of pathogenesis in someone who's immunocompromised. This virus is, honestly, a masterful hijacker. It's so clever. Once it gets into the nucleus, it unleashes its master regulator protein, the large T antigen. What does that do? It basically takes out the cell's own safety brakes, the tumor suppressors P53 and RB. This shoves the cell into S phase, turning it into a little factory that has no choice but to start cranking out copies of the virus's DNA. And once all the new virions are assembled, boom, the cell bursts, releasing them all. And that cell bursting, that lysis, well, it leads to two major clinical problems. The first one, and this is a huge deal for transplant medicine, is Polyomavirus-Associated Nephropathy, or PVAN. It can absolutely wreck a transplanted kidney. The other big one is Hemorrhagic Cystitis. This is a really painful and serious complication that we see mostly in patients who've had a hematopoietic stem cell transplant. Okay, so we know what it does, but how do we find it? This is where we, in the microbiology lab, become the heroes of the story. I'm not kidding. The entire modern game plan for managing this virus is built on our ability to find it and count it, quickly and accurately. You know, back in the day, the tools were pretty clunky. We had to rely on things like viral culture, which could take weeks, or we'd look for these decoy cells in urine cytology. The problem with decoy cells is, yeah, they tell you the virus is replicating, but lots of patients shed them and are totally fine. So the positive predictive value was pretty low. Honestly, these methods are just too slow and imprecise for how we manage patients today. Which brings us to the modern era. Today, it's all about one thing: quantitative PCR. The entire preemptive strategy, the idea of catching this before it causes damage, is only possible because of the speed, the sensitivity, and the quantitative power of qPCR. And when we talk about qPCR, the choice of specimen is absolutely critical. Sure, we can run it on urine, and that'll tell us if the virus is replicating. We call that viremia. But the real game changer is finding the virus in plasma. Seeing it in the blood, viremia, tells you the virus has broken out of the urinary tract and is now systemic. That is the key warning sign. That's why plasma qPCR is the gold standard for screening and the #1 trigger for doing something. Now, for a final definitive diagnosis, you still need a kidney biopsy. And here is the magic number. This is the one you need to remember: more than 10,000 copies per ml in the plasma. If you see a viral load persistently above that level, it's considered presumptive PVN. It's the alarm bell that means you have to intervene right now to save that kidney.
Okay, so let's bring this home and look specifically at the Dutch management guidelines. These were put together by the LANT, the National Consultation on Kidney Transplantation, and their entire approach is built around this proactive, preemptive strategy that's driven by the diagnostics we just talked about.
So what do? The principle is simple. You carefully reduce the immunosuppression, step by step. The moment that plasma viral load crosses 10,000, the first move is to cut the dose of the anti-metabolite, that's usually mycophenolate mofetil, or stop it completely. If the viremia still persists, okay, step 2. You start tapering the corticosteroids. And after that, you might carefully reduce the dose of the calcineurin inhibitor, the CNI. The whole goal is just to tip that immunological balance back, giving the patient's own immune system a fighting chance. Now, for hemorrhagic cystitis, it's a totally different playbook. Instead of a systemic approach, the Dutch guidelines really support local therapy. This means instilling the antiviral drug cidofovir directly into the bladder. Why? Well, it's brilliant, really. You get super high concentrations of the drug right where the virus is replicating, but you avoid all the nasty systemic side effects, especially the nephrotoxicity that cidofovir is known for. Okay, so that's the Dutch approach, but how does it stack up globally? Let's put it in context with the international consensus and also touch on a really important group: pediatric patients. When you put them side by side, the overall strategy is pretty similar, right? Reduce immunosuppression. But there are a couple of key differences. The international guidelines from the Transplantation Society, for instance, push for more frequent screening in that critical first year. But the biggest point of difference, and this is important, is that the international guidelines explicitly recommend against routinely using other drugs like cidofovir or leflunomide for PVN. They basically say the evidence just isn't there yet. And when it comes to kids, everyone is even more cautious. The screening goes on for longer, sometimes up to 3 years, and clinicians have a much lower threshold to go for a biopsy, even if the creatinine levels look stable, because that can be a really late sign in children. And you'll see that the use of those unproven adjunctive therapies, it's even more strongly discouraged outside of a formal clinical trial. And all of this really brings us to the core challenge of dealing with BK polyomavirus. The management isn't about finding a magic bullet antiviral drug. It's about walking this incredibly fine line, this tightrope, between two very bad outcomes. You know, we talk about resistance, but it's not what you might think. We're not really seeing resistance to antiviral drugs, mainly because the virus uses the host's own machinery to replicate. The real issue is something called immunological escape. What happens is, under pressure from the immune system, the virus can actually mutate its main capsid protein, VP1. It changes its shape just enough to hide from the patient's neutralizing antibodies. So the virus becomes resistant to the patient's own immune system, and that's the very tool we're trying to use to fight it. This forces a complete paradigm shift in how we think about infection prevention and control for BK polyomavirus. Let's be real, this virus is everywhere. Preventing people from getting it in the first place is impossible. So prevention isn't about stopping transmission, it's about stopping reactivation from turning into full-blown, irreversible disease. It is 100% a diagnostics-driven, preemptive strategy. And this quote really says it all. It perfectly sums up the knife edge that clinicians are on. Management is a sophisticated exercise in balancing the competing risks of uncontrolled viral replication and allograft rejection. You push back on the virus by reducing immunosuppression, you risk organ rejection. You protect the organ with more immunosuppression, you risk letting the virus run wild. It's a constant balancing act. At our quantitative lab data, that's the fulcrum on which the whole thing pivots. And that's why your role as a medical microbiologist is so incredibly important. Providing those accurate, timely, quantitative results, that is the absolute linchpin holding this entire management strategy together. Thank you so much for joining me on this deep dive. If you found this useful, please hit that subscribe button for more explainers like this. And let us know what you think in the comments below. We really do love to hear from you.